Hi, this is Irene, one of the ultrasound fellows here at MGH. Today I'm going to go over a simple guide to E to A ratio in diastolic dysfunction. I'm going to go over the technical aspect of how to measure the E to A ratio, a little bit on physiology, and talk about diastolic dysfunction, also known as heart failure with preserved ejection fraction. And lastly, how to interpret a few parameters. So first, how is E to A ratio measured and what is it? We start out first with an apical four-chamber view of the heart. And just as a reminder, this is LV, LA, RV, RA. Go ahead and then activate the pulsed wave Doppler. And this will allow us to measure the mitral inflow velocities. We align the beam, the Doppler beam here at the mitral valve leaflets. We place the sample volume of about 1 to 3 millimeter right at the mitral valve leaflet tips. What you're going to get then when you activate it is a tracing that looks something like this. The first peak in diastole is the E wave, and the second peak is the A wave. And if we were to measure this out, the E velocity here is 108.5 centimeter per second, and the A velocity here is 62.3 centimeter per second, and the E to A ratio is 1.74. So great, what do these waves mean? Just a brief reminder about the cardiac cycle. And here's the anatomy again, left ventricle, left atrium, RV, RA. We're just going to focus on the left side of the heart. What happens during systole is that the ventricle is contracting, the muscle is squeezing inwards, squeezing the blood out of the ventricle, out the aorta. At this point, the aortic valve is open and the mitral valve is closed, so that's systole. At the end of systole, the aortic valve is going to close. At the initial part of diastole, the mitral valve is still closed. The ventricle starts to relax. As it relaxes, the pressure in the chamber drops. And then when the mitral valve finally opens, the blood in the left atrium now has an outlet and fills the left ventricle. And whatever is left at the end of diastole is squeezed out by the atrium. So there you have it, the stages of diastole. Isovolumetric relaxation, that's when the AV valve is still closed and before the mitral valve opens. When the mitral valve finally opens, you get the early rapid diastolic filling. And at that point, the ventricle is going to start enlarging. And in fact, a majority of the LV preload fills in the ventricle in this phase. Then at some point, the filling slows as the pressure in the left ventricle gets higher with all the blood that's filling it. That's the low flow that occurs during mid-diastole. And finally, atrial kick contributes an extra approximately 20% of the preload. So this explains why early in diastole you get this rapid early diastolic filling, so you get that large E wave, and later in diastole you get the smaller A wave with the last 20% as given by the atrial kick. So what I've shown you here is really the normal waveform where E is greater than the A. Now let's talk a little bit about diastolic dysfunction. First off, lots of things can cause this. Either because the left ventricle's relaxation is either slow or incomplete, and we can see this in ischemia, especially in LVH, when it's harder to relax all that muscle. We can also see this if the left ventricle pressures are high or if there's just insufficient transmitral pressure gradient. Alternatively, you can see this when the ventricle's elasticity is damaged, such as the case in fibrosis or infiltrative heart diseases. And lastly, we can see this in pericardial constriction, such as constrictive pericarditis. So irrespective of the cause of the problem, the end result common to all these pathways is an elevated left ventricular end diastolic pressure. And that's elevated LV-EDP relative to the LV end diastolic volume that we have. So the stages of diastolic dysfunction are as follows. First, you have the normal phase. Then you get impaired LV relaxation. So that the early diastolic filling isn't great, you end up relying on your atrial kick. And this reliance on the atrial kick is important, as we'll see later. Then as the ventricle end diastolic pressure starts to build up with all the filling, eventually even the atrial kick isn't contributing much. So you end up getting this pseudo-normal pattern again. And lastly, you get very advanced reduction in compliance, and that's you get the restrictive LV filling pattern, and that's kind of late stage diastolic dysfunction. So what does this all mean with respect to the E to A ratio? Normally, we've already said that E is greater than A. And that's our pattern here, E greater than A. With impaired LV relaxation, the reliance on the atrial kick gives you this big A wave, so that A becomes greater than E. And here's a clip of this where the E wave is as such and the A wave is a little bit greater. In the later stages, as we said earlier, the E gets bigger than A again. And in fact, at the very late stage, E is much greater than A, and you can see that the ratio between E and A is actually quite large in this restrictive pattern. Unfortunately, there's no cutoff velocity that makes the diagnosis of diastolic dysfunction for you, so you really have to rely on the pattern of the E to A wave. So if the A is greater than the E, then we know that we've got a patient with impaired LV relaxation. But pretty much everything else shows that E is greater than A. So it's kind of hard based on the pattern alone to differentiate whether the patient is normal or whether or not they're pseudo-normal or in a restrictive pattern. So to differentiate normal from pseudo-normal and severe restriction, there are a number of parameters and measurements that we can make. Today we're really only just going to focus in on the tissue Doppler imaging. Tissue Doppler imaging measures tissue velocity, and specifically in this case we're going to measure the velocity of the annulus. We're going to again start with the apical 4-chamber view. And for tissue Doppler imaging, what we're going to do is line up the beam right along the septum, like so. We're going to then place the sample volume over the medial mitral annulus. And for this sample volume, it needs to be a little bit wider, 5 to 10 millimeter, as opposed to 1 to 3 millimeter for the mitral inflow velocities. Because for tissue Doppler imaging, we really want to capture the full excursion of the annulus as it moves up during contraction and systole and down again during diastole when the ventricle is filling. So the sample volume needs to be a little bit wider. So this is what it looks like. You get the S during systole here as the annulus moves up when the ventricle is contracting. And then you get the E prime during early diastole, which eventually slows, and then it goes down again, gives you the A prime during the atrial kick. So the pattern in a normal individual, again, is that E prime is greater than the A prime for the exact same reasons that E is greater than A for the mitral inflow velocities. For normal individuals, E prime is normally greater than 8 to 10 centimeter per second. For patients with diastolic dysfunction, the E prime becomes blunted and gives you a pattern like so. You've got your S here, E prime, which is quite a bit blunted, and the A prime. You can do the same measurements at the lateral annulus level. The lateral E prime normally has a higher excursion than the septal annulus, so the normal values are a little bit greater than the septal numbers. In the normal individual, the lateral E prime is greater than 12. It's important to do both sides if you have a patient with regional wall motion abnormality, for instance. And one last point I'm going to make is that big E, or E to the E prime ratio, conveniently happens to reflect LVEDP. So normal end diastolic pressure should be less than 8. Higher or greater than 15 is reflective of high end diastolic pressures. So there you have it. This table summarizes the patterns for you for the different stages of diastolic dysfunction. For mitral inflow velocities, E to A ratio, that's where you put the calipers right between the mitral valve leaflets. Big E is generally greater than A except for impaired relaxation where you're relying on the atrial kick. And to differentiate the other two abnormalities from the normal stage, we move on to tissue Doppler imaging. So what I've got in this table here is the cutoff for the septal annulus level. So if your E prime is blunted, you've got a patient with diastolic dysfunction. And then lastly, E to E prime as a reflection of LV and diastolic pressures. So here are the basic take-home points. For pulse wave Doppler measurements, E reflects early diastolic filling and A reflects the atrial kick. If A is greater than E, this is suggestive of impaired relaxation or early diastolic dysfunction. For everything else, we should be looking at tissue Doppler imaging, and a blunted E prime is suggestive of diastolic dysfunction. So keep checking back on our website for more tutorials and cases, and thanks for tuning in.